Dialogue with a Doctor, featuring Southwest Florida's leading physicians, hosted by Dr. Gregory Leach and Jim York.
Good evening. Welcome to Dialogue with a Doctor. We're here this evening to talk about skin cancer with Dr. Daniel Wasserman, who's a practicing dermatologist in Naples, Florida. And this is the first time we've had you on this show, and we welcome you here.
Thank you, Dr.
Dr. Wasserman, just give us a little background of yourself, and I know I was just over at your new office, and just tell them where your office is located.
Sure. I've been in Southwest Florida for about 3.5 years now. My education had taken me from Philadelphia to Stanford, California, to Boston, to Alabama, and then finally to Naples. And this summer, I ventured out on my own, and am now I started a practice named Skin Wellness Physicians. We're on Collier Boulevard, right at the corner of Rattlesnake Hammock and Collier Boulevard.
And I guess you just started your practice there, since July?
That's right.
In July, and so we're here to talk about skin cancer.
Mm-hmm.
Do you want to just
Sure.
start us
So
in on
we're in
it?
Southwest Florida, so it's sort of ground zero,
Right.
right? So we're closer to the equator, we have lots of sun, we have it all year round, and it's really an epidemic down here. I mean, when I moved down here, I almost had to get used to the fact that people in Southwest Florida almost have dermatologists like they do dentists, right? They have to
Right.
kind of get their checkup every year. And the issue is that it's a real epidemic with skin cancer right now. There is about 3.5 million skin cancers being diagnosed in the United States, and only about 2 million people. And unlike many other cancers where a lot of them will actually have a mortality to them, most people do survive skin cancer, which only means that they're probably going to get more skin cancer. So it's about 140,000 new cases of melanoma every year now. It's felt by 2015, 1 out of 50 or 2% of individuals will get melanoma at some point in their life, and 1 person dies of melanoma every hour in this country.
And how do we prevent it?
So there are several ways to prevent it. You can have prevention, and I really want to speak not just to the patients who are getting it, but the people who have future patients, which are also parents.
Right.
So we like to think of prevention in 3 ways. There's primary prevention. These are like public health policy
Right.
phrases. There's primary prevention. Primary prevention really refers to how do we stop that initial insult, right? So that is, I'm a young person, I haven't really abused the sun yet, really haven't had any sunburns, and that is sunshades on school playgrounds, making sure I'm not going out during the sunny parts of the day, really only really early or really late, sun clothing, sunscreen. Sunscreens are very important. Okay, and that blocks the initial start of the process, or shall I say, start the fire, right? The secondary prevention is kind of saying, okay, you've already started a fire, and now you've got these precursor lesions, right? So you don't go from 0 to 60, you might have some precursor lesions. And if we treat this sort of sun-damaged precursor skin, that will lead to preventing cancer. And then we have tertiary prevention, which I actually go over a lot with my patients down here because people are already getting skin cancer. So let's say I get 5 cancers a year, maybe I can decrease that to 2 a year. I can't get you to 0, but I can decrease that rate. So it's all about the number of new spots in a given period of time. So if I can lower that number, that would be tertiary prevention. And for both secondary and tertiary, you can kind of think of it as like growing weeds. So you're growing a lot of weeds in the lawn, and everybody who's worked in their yard knows that you can either pull the weeds or treat the lawn. And if you do one or the other, it usually doesn't work. So sometimes you got to do both. So what we'll do is we'll pull some weeds, and that might be maybe freezing some of the precancers, biopsying or doing surgery on some of the skin cancers, and then also doing some lawn care. And I tell patients that's really about treating the spots that we see and the spots that we don't see yet, and really improving the overall health of the skin so that we work on that tertiary prevention.
So the main 3 forms of skin cancer that I know about, the basal cell, squamous cell, and melanoma, are they all sun-related, and which are more sun-related than others, or?
Right. So we like to categorize them as non-melanoma skin cancers and then melanoma. The non-melanoma skin cancers are 95% of skin cancers, and that's the basal cell skin cancers and the squamous cell skin cancers. And with basal cells being far more common. A very interesting trivia is that where does a basal cell come from? Like what cell in the skin? It's actually the hair follicle. And so where are the two places on the body you don't get basal cell skin cancers? On the palms and the soles. The only place you can get the only way to get that is if you grow it on the back of the hand and you just were completely negligent and you let this thing grow onto the palm. But you will not get a basal cell in the palm of your hand or your sole because you don't have hair follicles there. The squamous cell is still part of that 95%, but is the less common of the two, and that's from the just from the epidermis. I think most people understand that their epidermis pretty much covers their entire body, and including the inside of the mouth, and even the inside of the eyelids. That's the lining, and that's where the squamous cells come from. 4% of skin cancers are melanomas. However, they get the most attention because 75% of skin cancer deaths are from melanomas. They're from the pigment-producing cells called melanocytes. So that's why we tell people when looking for melanoma, dark spots, changing spots, and I'm sure we'll get into that a little bit later. But and that's what we look for with melanomas. And then there's the really bad ones, which are 1%, and you never want those. And those usually are coming from some of the organelles of the skin, like the sweat gland or the oil gland, or some of maybe the nervous tissue of the skin. Those are bad. You never want those. But it's primarily basal cell in order: basal cell, squamous cell, and then melanoma.
And skin cancer is not hereditary, is it?
So there is. So there are some types of skin cancer but more importantly, I wouldn't think of it as hereditary as your skin is, your look is hereditary, right?
Okay.
So it's, a fair-skinned person is not going to give birth to a dark-skinned person generally, unless there's some cryptic genes from some relatives 3 generations before. So what you inherit is your fairness of skin, which is what really puts you at your strongest predisposition for skin cancer. So fair-skinned people, blue-eyed people, redhead people, that's a genetic predisposition, right? They have trouble making pigment in ways that people who are not redhead, so they are an increased risk for skin cancer as well. So it's more about your skin color in terms of your ability to protect against sun damage that really you inherit. Now, there are some genetic syndromes, but that's more unusual.
Mm-hmm.
But yeah.
And we have some slides here. You'd like
Yeah.
to
Sure.
bring
So
those
really
up?
to talk about who's at risk. So really, I want to say is that everybody's at risk. So everybody, first of all, is that in Southwest Florida we have a lot of more Medicare population than, let's say, other parts of the country. So we see a lot of skin cancer in that population, partly because it's an accumulation of sun damage over one's life, right? So that's obvious. But melanoma is actually the #1 cancer for people 25 to 29 years old, and actually the second most common cancer for people 15 to 29 years old. So older people and younger people. And in fact, darker skinned people can actually get skin cancer. In fact, they get a specific type of melanoma called acrolentigenous melanoma, which is a type of melanoma that you get on your palms and soles. Now, fair-skinned people can get that, but that's a less common common form of melanoma than the other forms of melanoma. But when darker-skinned individuals get melanoma, that you'll see that much more often. So I think we have some slides. So this is just an example. This is not Marco Island, but you could pretty much take this picture from Marco Island.
That's right.
Right? Grandparents living down here have the grandkids coming down. What's wrong? What's wrong and what's right? Right? Well, I wouldn't say riding a bike on the beach is right, but he's wearing a hat. Hopefully, he's got some sunscreen on, but maybe some better sun protective clothing. The child should have some sunscreen on, and really, what I like to make a point about this is the water. Whenever you're near a body of water, you're pretty much standing next to a mirror. So not only are you getting the direct sunlight from the sun's surface to your skin, you're actually getting it from the sun's surface to your skin and the sun's surface to the water, bouncing off the water and into your skin. So you're actually getting more sun.
Is that why they say you get a better tan when you're at the beach?
Yeah, that's exactly right. Yeah. I mean, I don't know the science behind that, but I would imagine that to be the truth. And then I think we have some. So this is just, look at this. Really shows you what chronic sun can do. You see the plump hand in the child, not a lot of wrinkles, and then you can see the more, shall I say, wise hand of the grandparent. The skin is thinner. A lot of times people get like easy bruising on the skin. I always tell people it's like you're packing wine bottles in a box full of styrofoam peanuts.
Right.
As you grow wiser, you have less styrofoam peanuts,
Yeah.
right? And if you have more sun, you get rid of those peanuts a little bit faster, right? And so you can see, and also the freckling that can happen from the chronic sun damage.
Mm.
And then here, this is an important one, and this is what I have to tell people all the time. So I love to ski. I grew up skiing in Syracuse, New York. My brothers live in Denver because they couldn't divorce themselves of skiing. And this is basically skiing on a mirror. So people think, well, don't you get more sun damage because you're closer to the sun? Not really. You get more sun damage because of the thinner atmosphere. So the atmosphere is a filter for the UV radiation
Right.
when we're at sea level, but when you're on a mountain, it's a much thinner atmosphere, so you get more UV radiation, and you're getting the reflection off of the sun. So it's like triple problems. So if you're skiing in the winter, please do not think that UV radiation is related to temperature. It has no relationship to temperature. It has a relationship to sun. So if you're getting sun, you're on a mountain, and you're on snow, it's triple damage.
And you're not feeling it.
That's right. That's right. You don't have those warning mechanisms. I'm feeling hot, feeling burnt, right?
Mm-hmm. Mm-hmm.
So,
You were going to talk about sunscreens.
Yeah.
Because I think there's misconception about that.
That's right. Well, I get a lot of questions about sunscreens. When the news comes to talk to me, they're always asking about sunscreens, and the question you get is SPF, et cetera. What do the numbers mean? I'm gonna spend some time here because this is actually a really important subject. It's a place where I think the market also tends to take advantage of consumers a little bit too.
Mhm.
So sunscreen is probably the most important thing that everybody should use. And people want to know how to look younger. Forget skin cancer. Let's talk about just looking young, right? There's probably no better thing to looking younger than starting to wear sunscreen every day, okay? So if I can't get people on the skin cancer, maybe I can get them on their looks, right?
Mhm.
Sunscreens are broken down into what's called chemical blockers and physical blockers. Now, I'm one of these organic nuts, so I tend to like to avoid the chemical blockers, but I have to say they're really good sunscreens. And the way the chemical blockers work is each chemical works by blocking a portion of the spectrum. UVA, UVB, maybe a part of UVA or in a part of the UVB, and they just throw enough chemicals that they kind of overlap and provide broad protection, okay? I just don't like chemicals because I'm kind of one of these organic nuts. But so I tell people to look at the physical blockers. The physical blockers are dumb. There's nothing special about them. They're basically microparticles of metals, titanium and zinc. So all they do is they reflect. They don't interact with a certain part of the wavelength. They are just literally like you're putting on a paste of a suit of armor.
Right.
It's a metal. So people are like, well, which ones should I have to remember? Just think metal. If it sounds like metal, zinc or titanium, that's what you want. They are broad, they are dumb, and they just reflect. So that's really what people want. The next thing that I would people need to understand is the SPF. So there's two ways to look at SPF. Well, first, let's go over what SPF is for. SPF is for UVB protection only. UVB is what you get on a sunny day. Now, UVA also causes skin cancer and can come through clouds. So when you're looking at sunscreens, you want to look for physical blockers, like I said, but you also want to have what they call broad spectrum coverage. The bottle actually has to say it. So you could have the highest number in the world for UVB, but if it doesn't say broad spectrum coverage, you're not getting any UVA protection. So you need broad spectrum coverage on that bottle. So what is actually the SPF? So the SPF is actually this. Let's say you get burnt in 1 minute. Very fair-skinned individual, burned in 1 minute, hypothetically speaking. If you have an SPF of 10, that means you'll get burned in 10 minutes, okay? However, here's the catch. Studies have shown that people who put on sunscreen put on about 25 to 30% of what they should be putting on to get that SPF. So what happens is, for instance, there have been studies that show people who put on sunscreen get more skin cancer. Well, they put it on and they think they're protected for the day. They're not, and not only that, is that not true because you only get about an hour and a half to 2 hours of protection, but you're not putting on enough. So if you get burnt in 1 minute, you're now getting burnt in probably 2.5 to 3 minutes, yet you think you're protected for hours. And so you're completely cooking yourself. So, so that's what an SPF means. Then the next question I get, well, do I need 100 or do I need a 50? Well, here's another way to look at SPF. If you're good at math, you'll understand me, and if you're not, you'll have a little bit of a harder time with this part. If you turn the number into a fraction, so you say 1 over 50, that's 2%. So 2% is roughly getting through the sunscreen. Go to 100, it's only 1%, but they charge you a lot more money. So they're basically, it's a total market ploy to charge people more money, 50 to 100. So much so, the FDA came in and said, done. No more 70, no more 80, no more 100. If you are a 70, 80, or 90, 100, you can only say 50 plus. Okay? So they basically call it 50 plus. And that means you're above 50 because people were just being taken advantage of. They think higher the number, the better. And that is true to a case, because let's think about it. Now let's go back and let's work in people's misunderstandings. If they're putting on less sunscreen than they should to give them the number, then the higher number is better. Because even less of 50 is still better than less of 10, right? So the thing is, I always say stay between 40 and 50, and that's really good. I think that 98% protection, I think, is very effective. I think I see problems 30 and below. I think if you can stay 40, 35, 40, 50, 50 plus, perfect, and broad spectrum coverage. And that's really what it is about sunscreen.
Well, we're going to take a quick break and come back and talk more about skin cancer prevention and any other sunscreen facts that you need to add in. So we'll be back in just a moment.
When picking a realtor, don't just pick anyone. Pick someone with experience. Pick someone with a proven track record. Pick a realtor like Jim York from Downing Fry Realty, the #1 brokerage with the most real estate transactions in the area.
My husband and I had very specific ideas about what we wanted in our new home. Jim York was able to help us find the home that was ideal for us.
With over 20 years of real estate experience in Southwest Florida, Jim York has negotiated over $200 million in sales contracts. Selecting the right realtor is a critical decision that can earn you thousands when selling or save you thousands when buying.
Jim also helped us with a mortgage lender and a good real estate attorney. He went that extra mile, and his experience says it all.
Call Jim York for a no-obligation meeting at 239-273-6727 or visit his website, www.naplesyorkrealestate.com.
You're ready.
Welcome back to Dialogue with the Doctor. We're here with Dr. Daniel Wasserman, a practicing dermatologist in Naples. And we're talking about skin cancer prevention, et cetera. We just got finished talking about SPF, sun protection factor, and how it can be a false sense of security if not done correctly. It's good stuff, but you've just taught us how to do it correctly. And now I think you wanted to talk about identifying skin cancer, what to look for.
So the skin, with the advantage of being a dermatologist, I don't have a stethoscope. And the reason is because the organ I evaluate is very accessible, which means it's very accessible for patients to evaluate their skin. So there's things that we like patients to really be on the lookout for. Some things that are definitely well-known public health initiatives, and other things that I can kind of give some clues for people to what to look for. So earlier in the show, I was talking about those pre-cancers, right? There's a name for it. They're called actinic keratoses. Dermatologists refer to them as AKs. But they're the pre-cancers. And some of my patients call it their Irish acne. And so what you do is you actually, if you feel in the skin, if you notice that, my skin's becoming a little bit more sensitive to shaving. I've got these rough spots that I can't make go away. Almost feels like dry skin. But what I tell patients is, does it feel like sandpaper? Does it feel gritty? That sandpaper gritty feeling is probably a precancerous lesion. You'll get them commonly, the first areas you'll commonly see them is on the lateral parts of the forehead, on the temples, cheeks, and then hands for sure, right? Golfers usually get it on one hand because they're usually wearing a glove.
Right.
And also from driving, having your hands on the steering wheel. A little factoid is that UVB does get filtered by car windows, but UVA actually makes it through just fine. And there's plenty of pictures on the internet of truckers who you can see the difference in one side of the face versus the other. So if they have dry spots, but it feels more waxy or silky, it's probably not as big of an urgent concern. But if you're feeling that gritty sandpaper feel, then that's what you should be looking for. And I think we actually have a picture of that.
That's what I thought.
Yeah.
We had a picture, right?
Yeah, this is perfect picture.
Yep.
So this is a male, older gentleman, and has some of those red areas. And I bet you, if I feel like my patients, they come, I'm constantly, when I'm examining them, feeling them. Because sometimes you
Right.
can feel these before you actually see them. And so if you feel these sort of, I bet you all those little red spots there would probably feel like sandpaper. That would be something that you should see a dermatologist for, because that's the weeds that I was referring to that people start growing. And the other thing you should look for in something in a more advanced stage with a squamous cell skin cancer or a basal cell skin cancer is basically a new spot that hasn't resolved. All right, I always say you're allowed to get things until you're 40, right? You're allowed to get new things until you're about 40. After 40, you're not allowed to get new things, okay? As a general guide. And so if you get a new spot you think is a pimple, and you're convinced it's a pimple,
Right.
pimples go away in a week or two.
Right.
If it's 2 or 3 weeks and it hasn't gone away, you need to see a dermatologist. Ever notice that you wipe your face with a towel after a shower and it bleeds? Maybe even goes away for a few days or a week, but comes right back and then bleeds when you wash your face? Definitely, bleeding lesions need to be seen by a dermatologist. Growing lesions need to be seen by a dermatologist.
I think we have a slide of
Yeah.
the squamous and basal as well.
Right, this would be an example of a squamous cell cancer, and you can actually see almost how it's kind of growing around the edges. This could be a lot of different things, but a red spot that's dry and flaking, particularly on a sun-exposed area, should definitely bring you to a dermatologist. I think we have another one of a basal cell. Yeah, we call them pearly papules. It almost looks like it's glassy a little bit. It all has those little capillaries on top of it, and it looks like it may, in this picture, for example, that was probably a spot that bled and now has a little bit of dried blood on top of it. Those are the things you kind of want to look for. And, or if you have any question, again, even if you're not sure and you're just anxious, see a dermatologist.
And you should be checking your hair, right, up in your
Yes,
scalp and
yes,
everywhere.
yes. So that's a really good point. So I actually always tell my patients who've had melanoma, there are 3 reasons to get melanoma. Sun, bad luck, family history. Okay? 2 of those don't require sun, which means that you can get melanoma where the sun doesn't shine. Now that's not exactly the scalp, but that leads me into telling patients you should recruit people who are evaluating your skin to look for lesions. For women, gynecologists, you can get melanoma down in the genital area, so you should have your gynecologist pay attention. In addition, your hairdresser, because your hairdresser it can be looking at your scalp and see things that you may not see.
I think we have one more slide here.
Yeah.
ABC slide.
This is the important one. This is for
Right.
melanoma. And we have a mnemonic. It's A, B, C, D, E. So we have A for asymmetry. We don't like one half looking different than the other. B for border. We do not like jigsaw puzzle pieces. Okay. C for color. We like the color to be uniform. It should be one color. I don't care if it's dark, light brown, whatever.
Right.
It needs to be one color. Multicolored, we do not like. D for diameter, we like them smaller than a pencil eraser. And E is the one that trumps it all. If I have a patient who comes in, and E is for evolution, if I have a patient who comes in and says something's changing, I don't care what it looks like. It can look fine, it can look bad, it's coming out. I've had some patients tell me that they've had a lesion that's actually been changing. I thought it looked fine. And in fact, I listened to my patient, I biopsied, and it was in fact a melanoma.
And I think we have one more chart here, right? Look at.
Yeah, this is going over treatments, and this leads me into treatment. I really want to talk about treatments because it's important. There's more than one way to skin a cat, right? So we have lots of different treatments. And I like to group them into 2 groups. There's the blinded treatments and the unblinded treatments. The unblinded treatments means these are treatments that we can actually check the margins and know that we got it all out. That's Mohs surgery, which has the highest cure rate, has the and also is the least invasive, meaning that we take out the least amount of skin. And then there's the blinded treatments. That would be radiation, which is a very good treatment in the right circumstance, but the radiation oncologist doesn't know how deep it is, doesn't know where the border is, and a lot of these skin cancers can be like what I tell my patients is a fried egg. We see the yolk, but the white is actually more spread out underneath the skin. And so what happens is we can sometimes treat what we think is the entire lesion, and then it comes back, and if it comes back in radiated skin, it's a total mess. We can scrape and burn it, then you get a scar. The scar's not as nice, but that's a perfectly appropriate treatment in some areas. But again, it comes back in a scar, can be a little bit of a mess. And we actually even have some creams that can treat skin cancers. And now you're talking about only like 40, 50, 60% cure rate, which is when you have a 99% cure rate and a 95% cure rate
Why
with some
would you do
surgeries,
it? Right.
you know, it's really more in for people who are poor surgical candidates or a poor candidate for any of the other procedures. But that picture, if you don't mind going back to it, with this is a perfect example of why Mohs surgery is valuable. So when you cut out skin cancer in a traditional excision, what they do is they process the tissue like a bread loaf, and they just take out slices of what you cut out, and they randomly check it. And in fact, studies have shown that when they do that, they're checking only less than 5%, in fact, maybe less than 1% of the margins. And that's standard. However, in the medical world, we find that to be acceptable. But in this picture, what it shows is a lot of times skin cancers can kind of have a finger that jets off to the side, and if they didn't check that particular slice, you miss it. Well, with Mohs surgery, which was invented by Dr. Frederick Mohs, who was frustrated with the recurrence rates of cancers in certain parts of the body, he developed a new way to process the tissue. First harvest the tissue, then process the tissue, and then map the tissue. We actually check 100% of the margins around it and 100% of the margin at the depth, and we can give patients a 99 to 98% cure rate when done by a fellowship-trained surgeon. So those cure rates are from studies done, are cure rates from fellowship-trained surgeons. And it's very important that I suggest to patients who are going to have skin cancer surgery by Mohs surgery to make sure that they look up fellowship-trained surgeons, and they can do that on mohscollege.org, mohscollege.org.
So when is radiation therapy appropriate?
I think radiation therapy is appropriate if it's a person who really, I think there's maybe some psychological issues. I don't mean that as a negative term, but just their anxiety level is beyond control for surgery, and that's understandable. I always say, God help the surgeon that's going to have to operate on me, or small areas, or people who really can't afford to be out. Functionality, really where their activities of daily living are so fragile, where if you ruin it, any of that with some surgery, you could really set them back.
What about in cosmetic areas?
Yeah.
I mean, is that?
So the cosmetic outcome for radiation is actually very good. But the one caveat is that cosmetic areas tend to have higher recurrence rates. So it's this balance about what's the best thing to do.
Well, we really would like to thank you for coming this evening. We've learned a lot more than we knew before.
My pleasure. Thanks for having me.
And I think this is a good subject for all our viewers, especially considering where we live. And for you, who needs to wear a hat.
Exactly. Yep. Well, thank you very much.
Thank you.
Yeah, my pleasure. Thanks
you.
a lot. Thanks for having me.